It's really going to be...
Sorry, what was it called again?
Sorry, I was supposed to enunciate.
Please say that one more time.
PNS stimulation. Sorry
Do I
about
have to bleep that? All right, we're back. Another episode of the OuchCast. My name is Neal Rakesh. I am joined with my host again, Dr. Gulati.
Hello.
How goes it?
I'm the doctor.
You're always a doctor.
So are you, Dr. Neal Rakesh?
I don't know. It seems weird to introduce yourself as doctor.
It's true.
So if I do it for you, then maybe you'll say the same thing for me.
You're right. We'll keep it out. I won't be saying that Dr. Gulati business anymore.
All right. So today's episode brought to you by the World Academy of Pain Medicine United, WAPMU, and we also have educational support for this episode by Nalu Medical.
Thank you very much.
And we are going to focus specifically today on peripheral nerve stimulation, or PNS. I'm going to say that slowly because you say it too fast.
The letters need to be enunciated
Yeah, if you say it too fast, it sounds strange.
I'd say it's a really cool and evolving field, a lot of innovation. And we got two of our esteemed colleagues here. Should I say Dr. Matt Pingree?
Sure. Yes, I'll take that. Mayo, I'll take that.
Mayo Clinic and the mothership at Rochester. That's right. You know, been a good mentor of mine for many years. And Dr. Einar Ottestad, who happened to be a Baylor College of Medicine graduate with me.
I prefer professor. This doctor stuff is garbage.
Professor Ottestad.
It's professor to you.
From Stanford University.
Were you guys like roommates?
No, we were in med school.
I think we barely met. We did the Blockbuster School of Medicine. It was all VHS recordings at home in the 2 days before the finals. Yeah,
and we showed up at graduation. He shook hands with Dr. Michael DeBakey.
Oh, that's right. He gave us a fantastic lecture.
And we're going to be talking, and obviously he's visiting us from Stanford. And, you know, I think we're going to be talking about this exciting field. And, you know, Einar, I'm going to say Einar because you're a colleague and I'm a friend. And then more than a doctor, to me at least.
Barely a doctor.
Tell me about this field. What excites you about it? What's your soliloquy? What's so cool about peripheral nerve stimulation?
Yeah, so the best part about this enlarging field of PNS stimulation is really going to be...
Sorry, what was it called again?
Sorry, I was supposed to enunciate.
Please say that one more time.
PNS stimulation.
Do I have to bleep that?
No, but the best part about peripheral nerve stimulation is it's really changed the way I think about chronic pain and what causes it and what drives it. And it goes back to learning about complex regional pain syndrome and residency and fellowship and what it is. And the way I think about now, peripheral nerve stimulation versus spinal cord stimulation, is chronic pain is all essentially a learned behavior. It's simply action potentials traveling down the same fascicle and the same nerve over and over for a few weeks. And that's really long enough to train that nerve to persist with that electrical stimulation. And that's your central sensitivity, your hyperalgesia. So to kind of explain the difference in PNS and SCS on treating this is if you have some sort of trauma to your foot, say you damage your heel, that heel is going to tickle the tibial nerve sends electricity up the spinal cord for a couple of days. Then the heel feels better and the electricity goes away. So your spinal cord can essentially accommodate that insult and go on with its day. However, if that trauma was to the tibial nerve, the problem is the tibial nerve doesn't calm down after 3 or 4 days. It's going to hurt for 2 weeks or 2 months or 6 months. And that's really long enough to get your 10,000 hours of practice in that tibial nerve hurting. So what happens is that electricity goes from the foot up to the spinal cord, and it never stops. So there's a faucet of glutamate really being released in the dorsal horn, and it spreads out, affects the other fascicles. We have allodynia.
Yeah.
When I try to treat that with SCS, it's just simply too late in the pathway, right? The spinal cord is getting sensitized by that tibial neuropathy. So spinal cord can fail over the course of a couple of years. But if I find that right nerve and put a peripheral stimulator on it, I think of it as basically replacing that pathologic electricity with basically soft A-beta touch.
Right.
And as long as I can make that foot feel pleasant with a little buzzing for a few days or a few weeks or a few months, however long it takes, I'm slowly unwinding that central plasticity that was wound up by the insult. So in some ways, with PNS, I'm reversing those central changes that happen with the insult, whereas with SCS, I'm kind of palliating it just a little bit.
So do you practice that in the mirror like every day?
It was well done.
that was like I've said this before.
I got a question.
I have lots of fellows. I say this 4 times a day.
The same thing over and over again.
I have a good question though, Matt. You got all this stuff we learned in our talking about. How do you convince a patient, and how do you pick your patients for peripheral nerve stimulation? Even how do you tell a patient this is a great option, not SCS, not pumps? not injections, not morphine.
Well, it's very interesting because I'll start off right off the bat and tell them that I am very much biased towards some of the newer stuff. And I'll talk about peripheral nerve injury and peripheral nerve pain and some of the central sensitization like Einar was speaking of. And I kind of will go through the different steps from, physical therapy to, medications and step through the process to get to the point where we start talking about neuromodulation. And I start, I talk about how exciting it is. There's this new technology and it's very minimally invasive. Some of it's temporary and something that really is very effective. And I talk about it up front right off the bat rather than waiting until the very end or the last, kind of the last hurrah kind of treatment that sometimes we put it at.
It almost sounds like Star Trek. It's like a little wand and feel better.
So now, just to kind of clarify, so basically you, in your algorithm, you obviously go through all the basic conservative things, physical therapy, medications, you have the injections, and then you get to the more interventional things. Obviously stimulation, temporary being an option, there are obviously permanent ones as well. And the whole premise is you're stimulating non-painful fibers, so the A beta fibers, and that's it's a distraction of pain. So what can you particularly use this for patients? What are the conditions that you're using this for?
So, if there's a particular insult to one of the nerves, so many times a surgery that may have left a painful nerve, so an ulnar transposition, for example, or a crush injury after a motor vehicle accident, or even a traumatic thing that would end up with something like complex regional pain syndrome, all of those things would potentially be treatments with peripheral nerve stimulation.
Yeah,
CRPS. What about knee
CRPS.
osteoarthritis? I heard a lot of people doing this for knees now, and it doesn't seem like an insult necessarily.
And so that's a whole, so rather than just using the sensory fibers, that we're stimulating, there are some actual benefits for motor stimulation because there's some feedback within the muscle itself.
Oh, interesting.
That can also help balance some of that inappropriate, painful feedback that people are getting. And it turns out that from joints like knees and shoulders, there can really be some benefit from that.
I also want to add in that with musculoskeletal pain versus neuropathic pain, we classically think of neuropathic pain as being better for neuromodulation. But the way I think about it really is it's not the descriptors or the cause. It's kind of the volume of electricity. So if someone has a painful joint, but it hurts at baseline, that neuromuscular system is going to function almost like a CRPS type of thing. So then you can go in and you can actually target that somatic nerve and get benefit for what you would consider to be MSK pain. Because that nerve is simply firing all the time in that setting. So electricity becomes a reasonable treatment for it.
Gotcha.
So that idea of dumping people in a pail of water and there's an eel inside and shock you actually makes sense now.
Yeah, it takes care of migraines too.
But it's even the inception, correct me if I'm wrong, the inception of peripheral nerve stimulation was used in post-stroke shoulders. That was kind of some of the earlier stuff. Am I wrong?
That's where it began.
Yeah.
And so again,
modern devices,
Yeah, obviously, the eels, that's probably the first thing.
But they noticed that those shoulders were popping out of joint, right? And they were subluxing. And they thought, again, they looked at a mechanical kind of fix for it by stimulating enough to put it back into the joint and found that after that stimulation, even though it didn't stay in the joint, there was still a lot of benefit from having stimulated the muscle.
Yeah, and even amazingly, they stimulated for 3 weeks and pulled the lead out and still had persistent benefit for the duration of the study. And I think they went out to 3+ months.
Yes.
I guess one question I want to know is, what does stimulate actually mean, right? We're talking about stimulating all sorts of stuff, but is it what does it mean to the people who are listening to this? What does stimulate actually mean? What are we doing to these nerves? Are we making them activate? We're trying to shut them down? Are we trying to do everything?
So again, we're providing...
trying to do everything.
we provide electric...
It's confusing.
We provide electric current, right, or electric stimulation to the fibers within the nerve. So you're activating the nerve, and we're obviously trying to activate the fibers that don't carry the non-painful fibers to, again, provide some upstream kind of re-regulation or to help correct the imbalance in some of the inputs to help do that. So again, electrical stimulation on the nerve is what we're talking about. And it's not, the idea is that it's not painful. We don't want it to be painful. We don't want it to cause necessarily big muscle contractions, but it's something that, again, sometimes it's even sub-threshold. And some of the newer technology now allows us to have different wave forms or different types of stimulation to even take it to the next step to look in more different ways in which we can apply this technology to the peripheral nervous system.
I like that. I feel like we're gonna go back to some of the more logistical things of these devices, but just as kind of like a basic thing. So now we kind of have an idea of the conditions we use them for. What are side effects, risks of starting to get a little bit more kind of like when you implant these devices, temporary, permanent? What are the side effects of doing something like this?
The interesting thing about peripheral nerve stimulation is it actually predates spinal cord stimulation, and people were putting these in already in the 60s and seeing good results.
Yeah.
But the downside was the technique and the equipment and the risks that went along with it. So you would have migrations and infections, you'd have hardware failures, and really the resurgence in the last 5 years has been solving the technical problems. So it's been externalizing the batteries, having less wires, and having leads that are actually designed for the periphery so they don't bend and migrate. And that's been kind of the latest big update for us.
Much of I'll talk to people and they'll say, peripheral nerve, there's too many adverse events related to the procedure.
Yeah.
This almost invariably has to do with the fact that we're using a spinal cord stimulator lead on the peripheral nerve. So it was using the wrong tool for the wrong job.
It just sounds like we have a lot of cool new tools, and they seem like they're very different from each other when it comes to peripheral nerve stimulation.
What about like the risks of like infection because you have like a device that's inside of you, or like is there like something like nerve damage that can happen? That's something that we like always say with like an implant or a device or even just an injection. Does that still exist with these?
I would say you still have all those same risks, including the risk of nerve damage.
Yeah.
But the variety of devices that we have are essentially designed kind of in a blunt fashion.
Yeah.
And it turns out that it's actually a little bit hard to get needles into nerves. You tend to just move them out of the way, push them out of the way with the blunter instruments. So I haven't seen any even neuropraxia or any sort of issues from implants of peripheral nerve stimulators from like a nerve damage point of view.
That makes sense. What about like, is there any particular things that you would say that makes for a good patient? Like when you see someone, how do you know that they're gonna be like, this person's gonna do well with a stimulator, like a peripheral nerve stimulator?
Well, I'd say if you have neuropathic pain that seem to fit within one nerve, many times that's an ideal patient. Ideal, and even more ideal would be if it was relatively early on in their course of pain.
When you say one nerve, is that a peripheral nerve, or is that like
peripheral nerve? So like a median nerve or an ulnar nerve or something like that.
What about like a nerve root? Can you do like one dermatome?
You potentially, and that's kind of pushing the limit on what the peripheral nervous. Some of the devices are actually been approved for. Yeah. But yes, I'd say that's definitely headed in that direction where we are going to start looking at putting it nearer to the nerve roots to provide a dermatomal kind of relief.
Interesting. What about like bad patient? Like, how do you know they're not going to do well? Is there? I feel like with devices, it's always like there's a support system that exists. Like if you don't have adequate support, someone that can like, if there's something you have to change, if there's something you have to update, like, or you can't even look at a phone, for example. Is that not for this patient?
I like to divide patients in kind of two main categories when I first meet them. And you get a sense within the first probably 5 or 10 minutes, or you may get the sense from the chart review and the referral. But you kind of have surgical pain, people that were working and walking and talking, and they had a surgery or a trauma, and now for the last 6 to 12 months, they have some sort of pain condition that corresponds to a peripheral nerve being injured. These guys do wonderfully, and you can essentially cure their pains. But then you have the folks that they may have that same history, but they also have fibromyalgia and chronic headaches, and they have had 2 knee replacements, and they may have a little saphenous neuropathy too. Mm-hmm. So they may still respond to the device, but they're still going to be a chronic pain patient. They're still going to have all those other surrounding behaviors. So in some ways, you have a surgical pain population, and you have kind of a medical pain population that they may need pain procedure still, but they also need that life coaching bit if you really want to get them back and rehab.
Yeah.
We've also been interested in stimulation, improving nerve healing. We talked about that a while back.
Yeah.
I feel like you mentioned that. Yeah. Like the first time I heard you talk, that was something you said that.
Has that ever happened for any of your patients, or what are your thoughts on that? I know my thoughts.
Yeah, so the evidence for that really comes from the surgical literature, right? So if you look at surgeons who decompress the ulnar nerve in the cubital tunnel or the median nerve in the carpal tunnel, so the way the studies are done is you leave a small wire adjacent to the nerve and just close on the wire, and they're only stimulating for 30 minutes in PACU and pulling the lead, and then measuring things like grip strength over the course of 1, 2, and 3 years, and you see improvement in the electrical stim group. But if you kind of think about it, what's the stimulator doing? It's really just activating that nerve, activating that muscle, the same way going to see the physical therapist would. So it's kind of a boot camp of putting electricity into the system and letting the brain and spinal cord kind of recognize, hey, I gotta heal this nerve.
So you're saying that ab work can actually work.
I was
now.
literally just going to say that.
Work on my abs, right? That's it. It makes sense now.
Yeah, it clearly works, right? For
Well,
the abs?
maybe I didn't put those in the side of the abs, though, the wires. That's maybe the difference.
So you're saying that if you put them directly
Maybe
into
it
like
makes more
PNS
sense.
into the abs?
You'll go show that live.
That sounded funny.
I could use a musculocutaneous one over here.
I guess we're going to get a little bit more detail. We got these devices that are like one contact, multi-contact, all stimulators. How do you choose? Like, some of them obviously have their temporary versus permanent, but when it comes to more targeted things, like certain nerves are amenable to like some of these like different devices. Like, what would you tell someone who's kind of starting in this field? All right, use these devices for this reason.
Yeah.
Where do you go for this?
I mean, I guess I depending on the area in which you think needs to be stimulated. So some of the multi-contact products, their leads are going to provide a wider or a larger area of stimulation. So an area that would need a wider area need of stimulation, something like a sciatic nerve or maybe a cluneal nerve area, would be something that maybe a multi-contact system might be better for, as opposed to a very focal spot where you're trying to stimulate where it would be just one lead that you need to place.
Yeah, certainly any areas where there may be a couple of nerves passing by closely, like a greater occipital with multiple branches and third occipital and lesser in the back of the head, or cluneal with multiple branches are perfect examples. And you also have a little bit of built-in guarding against migration, right? If you slide in or out a centimeter, there should still be an electrode that's going to be useful for you.
But also having multi-contacts like that opens the door to different waveforms and being able to stimulate differently as well. So there's more flexibility, I think, built into the system.
Are there some variables that you tell, like you say you try waveforms? Everyone says waveforms, but there's some variables that you think are important?
Yeah, what does that mean when you say waveform? Like,
Everyone wants to know.
Why does that matter?
So the frequency with which you stimulate different fibers, so frequency is one parameter of the waveform, is going to determine on what kind of stimulation you're going to get. So muscular stimulation is a very different frequency and amplitude, which is another part of it, than sensory stimulation.
Yeah.
Right? And then if you talk about, in the spinal cord stimulator field, right, high frequency stimulation of the spinal cord has been a hot topic because it's been quite successful and you don't even feel that kind of stimulation. That kind of thought process now applied to the peripheral nerve system is kind of where we are. And some of these multi-contact systems allow for different choices to be made. I think a lot of it is to be determined. We don't necessarily know at this point.
Sounds like it's a lot of fun. We can play with the waveforms, and if one isn't working with the multi-contact system, we can switch to another one, and there's a lot of variability that we can still learn from and figure out.
Yeah. Is there a drawback to using a multi-contact system? Is there what makes it difficult? Is it like very easy just to do, or is there like things you want to worry about?
I will say all of our peripheral nerve stimulator systems are basically fairly straightforward technique-wise when we compare it to the spinal cord systems. They're all fairly straightforward, probably 30, 45 minute procedures. The multi-contact leads are simply a little bit longer.
Okay.
So if you worry about body habitus, maybe it would be a consideration, but overall the sizes are still fairly similar, and most patients won't feel any of these under the skin.
Okay. So, but it all kind of comes back down to patient selection. You want to choose the right patient, the right set of nerves or distributions. Like, it sounds like multi-contacts tend to be there's an even greater benefit when it comes to like plexus of nerves or like the cluneals. Does anyone do geniculars for them? Like, I mean, that seems like
I've seen it done. Yep. Sure.
Okay. So that seems like an ideal thing for like multi-contact systems. How do you place it? Is like, because there's a lot of mentality with like different ways in which the nerve exists. Are you placing this like in line with the nerve? Are you placing this kind of like at an angle? Like, how does that work?
So the way I've been thinking about electricity and all the nerves is a little bit to follow on your question earlier is if you wrap a lead around the nerve or use really high frequencies, you can get conduction blockade. You can actually turn nerves off with electricity, but you can't do that percutaneously, right? You need open surgeries to wrap these leads around the nerve still. So no one is really doing conduction blockade for peripheral nerve stimulation. What we're really doing, as mentioned earlier, is tickling those A-beta fibers. So far, it hasn't...
Very technical.
Nerve stimulation, yes.
Like, that got real medical.
Dr.
Right
Ottestad went from
That's
glutamate
right.
receptors
He's
to
like the
tickles.
professor said tickling.
Tickling, that's right.
It's a technical term.
You know,
It's a Stanford way.
replacing the soft skin touch.
Stanford. He's like, this is not going online ever.
This
I
is
don't know.
perfect.
Sorry, Dr.
I
Mackey.
forgot what my question was.
Okay. I don't even know where we were.
Yeah, I lost my train.
Finish your thought. You was tickling.
You're
it was
tickling the nerve.
data.
Well, why?
You're tickling all of us.
I forgot why I was
tickling all of us. You're tickling all of us in your conversation.
This is for the Ouch takes.
I
We're
literally
talking
forgot
about
what I was saying.
orientation to the nerve.
Yeah.
We're kind of heading down that. And you're saying that the way you think about peripheral nerve stimulation.
So what I was saying is, you can either get the unstimulating conduction blockade to make the pain go away, or you add electricity to the system with whatever waveform you choose. My point was just going to be, it doesn't really matter so far. Basically, as with the approach where you're tickling the A beta fibers, the flavor of electricity doesn't really seem to matter as much as the patient says, I have a pleasant paresthesia covering the pain. So in my mind, the goal is that for the next 2, 6, 12 months, the patient doesn't feel the burning, shooting, stabbing. They don't feel that underlying dull ache. And the longer amount of time, the more hours to spend in that pain-free state, the more likely you are to get to a point where the pain doesn't necessarily come back quite as severe.
You're unlearning that chronic pain.
This sounds so cool. When someone watching this first time, maybe just starting learning about peripheral nerve stimulation, where do they start? Where do they go learn this stuff? Like, what do you guys recommend? Because when we were doing this, like, it was one by one, someone came to us and said, we have this device and we're trying to apply it. But now, on the other hand, we have a lot of stuff to teach. And how do we start like putting it all together and giving it in a piecemeal way?
I think, well, again, looking at it from my perspective, I think most of what we're doing with peripheral nerve stimulation at this point is a lot of it's ultrasound based. And so I think if you're going to start doing this, I think ultrasound, having a basic knowledge of ultrasound would probably be helpful. Mm-hmm. There are people who do it just fluoro, and that's fine too. But learning the anatomy of the nerves, learning if you're going to do ultrasound, getting good at being able to find the nerves. And if you can do a block around a nerve, you can pretty much do a peripheral nerve stimulation lead placement around a nerve, because most of them are very similar.
Yeah.
And so that would be kind of the way to start, is make sure that you can identify an image correctly to get it where you want it to be.
Yeah, 100% agree. We had the advantage, like you say, of growing up with ultrasound and being proficient, and adding peripheral nerve stimulation was fairly easy. The good thing about where we are in the field now is we have a lot of fluoro-guided techniques, and there are several targets that are just as viable with fluoro as ultrasound. So you can definitely start getting some patients better without spending $10,000 at ultrasound courses.
Makes sense. But obviously, I think we're all beating around it, but Wappman's pretty good at training a lot of these.
And we're nowhere near $10,000.
I feel like I was hoping someone would say it. I didn't know I'd have to say it.
$999.99.
Yeah, and you get abs with it too.
But yeah, I mean, of course, you come to WAPMU, you learn both with ultrasound and fluoro. You'll kind of get broad experience. You don't have to be an ultrasound expert as well.
That's why, I mean, like, I'm saying that from experience of, like, when I was starting, obviously as a resident, I'm learning from all of you, and that's kind of how I learned ultrasound. I learned about all these technologies and how to approach them. So, I mean, it's obviously great because I've learned it, but a lot of people come to these conferences and get the same exact.
And it's definitely fun because, unlike spinal cord stimulation, we're putting the wire in the same place. We get to teach different ways. All of us probably target the same nerve differently, and there's a bunch of nerves. So there's a lot of things to learn, but also fun to teach and think about how we're going to approach peripheral nerve stimulation. It makes a lot of innovation apparent and teachable.
It's fascinating because they're almost every couple of months there's a new nerve that someone's asking me to block, and I'm thinking about a new way to put a stimulator in, or if it would.
They're discovering new nerves?
Not new nerves, but new ways, new places to inject or put the needle or put the little lead in. Yeah.
I discover new nerve still. I'm like, what is that guy? And then I go look it up, and all of a sudden, there's a whole new pain syndrome.
They were discovered, it's just I didn't know about them. Right? So they're discovered to me.
He's like the Einar nerve. Just like writing books with his name in it.
It definitely can be tickled.
Very easily.
The tickling technique. What we talked about imaging. What, just real quick, if a patient gets this, can they get like MRIs? Can they get CAT scans? Is there any contraindications when you get these devices? What do you have to keep in mind as a patient?
At this point, we're mostly MRI conditional
Okay.
for the majority, and of course, if you have a temporary device, you're going to have to pull it out before you get an MRI in that particular case.
Okay, conditional meaning that there are specific conditions that the radiologist has to like protocol before they can do it. But
Yeah,
they
you
can
have
get
to.
it.
It's basically kind of a MRI light in some ways. 1.5 Tesla in some cases, and you have to adjust the parameters a little bit.
Okay.
And sometimes you have to make sure that you don't have the lead perfectly in the middle of the coil.
Interesting.
Yeah, but you can MRI. I think most of the manufacturers now.
And sometimes a 45-minute MRI turns into a much longer procedure
Right.
because they have to adjust things.
What's like the worry when I've always kind of wondered with these, like, what's the worry with the device when it's MRI conditional and you do, like, what if you do a 3 Tesla MRI with something like that? What happens? Does it, like,
So
get
that's
pulled out
actually
of the
really
person?
interesting because I had this patient in follow-up on Wednesday.
Yeah.
And she was seeing me for low back pain, and she already had I believe it was a sural stimulator implanted for a pre-existing CRPS.
Mm-hmm.
And I'm talking to her about, the guidelines have changed and we can get MRIs now with the stimulator in place. Yay. So now we can get a lumbar MRI. So I opened up her chart and she's at 2 in like the last 3 months. And, clearly everything was fine.
Yeah.
And she told me that she disclosed the stimulator to the radiologist, and I guess they were okay with it.
Oh,
But clearly nothing bad happened with a full 3.0 Tesla MRI and the lead, basically almost in the machine.
Just technically, they can heat up.
Right.
That's
Okay.
the main concern.
And then it just destroys whatever.
I don't
it's around.
recommend doing this, by the way. But
Yeah.
to your question, what will happen? Well, I know of one case and nothing bad happened.
Okay. No, I'm just curious. Like, it's like patients will ask you, like,
No,
what,
100%,
like-
yeah.
And so you just want to know, like, what is the risk? Or, like, will you explain it to them? This is why you're trying to avoid doing that.
Yeah. The lead heating up and burning the nerve is the risk.
Okay.
Technically, the MRI is making the electricity, kind of like what we're trying to do anyways.
It's like you go.
You might
go-
get pain relief.
It's
Well,
tickling
like-
them.
I don't know if I call it tickling at that point.
Well, it's like you go from like stimulation and then you go to ablation. So it's the same thing. You just get an MRI. Once you place this, you get an ablation.
Spin it up. Spin it faster. Spin it
Called
faster.
it a failed
spin it-
stimulation intra-op, and you go
Yeah.
straight to ablation right away.
Yeah.
Just someone get the MRI.
Get the 7T. Get the 7T right now.
Let's ablate that nerve. It's not working. So just to kind of summarize a lot of this. So basically, we have patients that can have any kind of nerve injury, specifically if there's some kind of like identifiable peripheral nerve, but could even be like a nerve root, CRPS, where you have these kind of ridiculous pains that are localized in a specific like extremity. It could even be muscular related pains that we use these for, even low back pain, and it activates non-painful fibers as a means to distract, as like a conventional mechanism. But you were also saying that it could be
Distract and re-educate.
And
is
re-educate.
the way I think about it now. Yeah.
Okay, I like that. And there are a lot of different things, like applications you can use this for, and a lot of different ways in which physicians can use them, like how you orient them, how you plan to use them for like different plexuses of nerves, and even planning for if it does migrate. Multi-contacts may allow you to still reprogram and get different types of stimulation depending on where the lead is. So it seems like there's a lot of play with this. It's a lot different than like spinal cord stimulation, where it's just place and then that's it. It's just
Yeah,
there.
spinal cord stimulation is more or less the same procedure every single time, right? With peripheral nerve stimulation, I feel like the patient experience is more enjoyable. It's a little bit of a detective work.
Yeah.
You have to do a little workout. You have to think about it. You do an exam. You're looking for tunnels, trying to figure out what's the target.
Yeah.
And you do a little block. And if the patient feels better, then you move to the stimulator to try to get them better and reverse some of these central changes. But it's kind of fun to look for these lesions rather than just palliating with a spinal cord stim and not really having a specific diagnosis. And then I think our results end up being better as well.
Nice. Well, I know this is like, as we said, it's like a new field. It's like up and coming. I mean, it's obviously been around for a little while. What's in the future? What's coming? What are you excited about? Is there anything specific? And Amit, you can say too.
I'm a moderator, wouldn't you?
You are an expert too.
Yeah, well, I'm excited by the waveform. I think the one thing we don't know is we don't know what actual currents, what actual parameters, whether it's the pulse width, pulse shape. We don't actually know what influences the nerve specifically. And looking at different parts of the nerve, at some point we're going to break it down nitty gritty and work on these sodium channel, potassium channel to figure out what actually can stop conduction, what actually causes conduction that's pleasurable, etc. I think that's where we're going. I think these devices are really cool. These multi-contact systems and monopolar systems can do things differently. We just don't know what to choose always. And I think that's a little bit different in spinal cord stimulation, where they're a little further ahead.
Yeah. What about you, Einar?
So I think the most exciting piece for me is really moving peripheral nerve stimulation outside of pain. looking for other applications. For example, stimulating things like renal artery for blood pressure, or stimulating something for insulin release, or
So now you're
something
tickling
like
the
that.
kidneys.
Tickling the kidneys.
Or pancreas.
What we're talking about. Or pancreas. You don't want to tickle the pancreas too hard. Be careful with those. But other areas, and certainly stimulation for mental health is also getting a little bit more interest. Vagal nerve stim for things like PTSD.
Yeah.
It's all related. All pain is electricity, and my job is to try to figure out to move from part A and move it over to point B. So it doesn't hurt as much.
I think some of the technology that continues to come, so the battery sizes, or figuring out if we're going to always keep external batteries or not. The leads continue to get smaller and easier to place and more effective. And I think even some of the spinal cord stimulator new arrival, like the closed loop systems, how would that maybe apply for something in a peripheral system? I mean, there's lots of potential options out there to think about.
That is actually, I mean, Amit knows how excited I am about that, because I think I called him one day or texted him. I was like, I want closed loop.
So
on the peripheral nerve stimulation, anyone listening?
Yeah, I feel like every podcast or something, you're like, well, we should not say this. We need to invest in this. But that's an interesting thought process, to be able to essentially record what's going on in a nerve and then modulate your response like in kind of a live fashion. And that's like EMGs, and it's like very crux of it. Just like we already do that. We already have the data for like how nerves, especially in the peripheral nervous system, react. It's a little bit different than like the spine.
I'll even take it one step further, and if you combine that spinal cord system with the peripheral lead, they can communicate together. And then maybe you can send electricity across a lesion in the central nervous system. Yeah.
And then I'll take it a step further. You connect it to your
robots.
Apple Watch.
Oh yeah.
And you see your spine, and you're just like
I want to run faster. You just dial up, and you.
Or maybe the Apple Watch controls you.
What is that? Isn't that like that's a movie, right?
I'm sure.
I can't remember that movie where it's Upgrade, where the guy has he has a spine. Never mind. Okay.
Johnny Mnemonic. That's right. Blast from the past.
that's right.
All right. Is there anything else that we missed out on? I feel like we touched on a lot of stuff.
Nah, this has been great. It's been wonderful to have my dear friends Matt and Einar.
Yeah.
Talking about this topic.
I love learning about tickling nerves. That was
just a disclaimer:
exciting.
no animals were electrocuted or tickled in this podcast.
Well, maybe an eel a long time ago.
We're talking about it, but it never happened. No, but it's great to see this field and watching it grow. And we've been part of it for so many years that it's kind of fun to see it evolve the way it has, and hopefully it continues that way.
Well, the best part is every single course, there's just new people that come up and ask questions and are really interested and as excited by it as we are. So we're excited to teach and talk about it.
Awesome. Thank you for joining us on the
Thanks for having
podcast.
me.